Good morning, everyone. As the clock strikes 11:03, we'll go ahead and get started. Today is our Wednesday Grand Rounds, May 1st. Rabbits to anybody who celebrates. Happy May Day. My name is Rebecca Muley, and I'm one of the Grand Rounds co-directors, along with Doctors Adi Talati and Alex Harris. Next week, there will be no Grand Rounds here due to the APA meeting. Our next Grand Rounds will be on May 15th and will be presented in person by Dr. Christina M. Deligianidis. The title of her talk will be Neuroactive Steroids and the Pathophysiology and Treatment of Peripartum Major Depressive Disorder, a Translational Research Journey. We hope that you'll all join us. For upcoming Grand Rounds, please visit our Grand Rounds calendar online. And if you would like to meet with the speaker, please email the Grand Round co-directors at grandrounds@nisbe.columbia.edu. I want to take this opportunity to remind you all that the next virtual town hall for principal investigators is on Tuesday, May 14th at 10 a.m. The next researcher roundtable is on May 7th at 2 p.m. for students and postdocs. And there's a roundtable for research staff, research assistants, research coordinators, and data managers scheduled for Tuesday, May 14th at 2 p.m. Roundtables are held in person in this auditorium with a Zoom option available. To view the schedule for upcoming town halls and roundtables, please visit the Safety Review tab of the HRPP section on Insight. And as our usual Q&A information, please do post any questions if you're joining us online using the Q&A feature, not the chat feature. Do list trainee at the beginning of your question so that we can highlight your question. And also for any trainees in the audience, please do think about your questions as you hear the talk from our lovely speaker who's about to be joining me at the podium. You can also write on the Q&A, ask question myself, and we'll be able to promote you to a panelist, and you can be on the big screen with us to ask your question yourself. So today's Grand Rounds, today is my great pleasure to welcome Dr. Rinad Beidas, I practiced that, as the Essock Lectureship Endowment Series speaker, an award chaired by Dr. Lisa Dixon, the Edna L. Edison Professor of Psychiatry and Director of the Division of Behavioral Health Services and Policy Research. I'd like to ask Dr. Dixon up to the stage to formally introduce the award and Dr. Beidas.
Good morning. It is such a pleasure to be here and to be able to introduce Dr. Beidas and have her share her vision and her work with us. I'm going to say a little bit about the Essock Award. The purpose of this award is to fund an annual lecture by a scholar in the field of mental health services whose work has had an impact on mental health policymaking. And Dr. Susan Essock, who retired a few years ago, who I think is going to be watching today, funded this award, and it really kind of epitomizes her vision and focus as a services researcher. Her career emphasized facilitating the translation of research findings into mental health policy and practice, addressing problems faced by mental health administrators, and evaluating the impact of behavioral health services delivered in routine practice settings. A common theme in her research has been creating scalable ways, and when you know Susan, you hear scalable ways to implement new services, monitor implementation fidelity, and measure outcomes to assess the extent to which the intended services are indeed those being delivered. The Essock Lecture will be given by a mental health scholar whose work exemplifies one or more of these components. And we're very happy today to honor Rinad Beidas, Glad Rinad Beidas. I try really hard with the pronunciation. If you remember the word glad, you got her first name. Dr. Beidas is chair and Ralph Seal Paffenbarger Professor of Medical Social Sciences at the Feinberg School of Medicine at Northwestern. Previously, and at the time that I met her, I think we're not 100% sure, but I think maybe it was on study section. Dr. Beidas served as founding director of the University of Pennsylvania Implementation Science Center at the Leonard Davis Institute. And she really is one of the key people to transform observation of implementation into an actual science. Dr. Beidas' research leverages insights from implementation science and behavioral economics to make it easier for clinicians, leaders, and organizations to use best practices to improve the quality and equity of care and enhance health outcomes. As an international leader in implementation science, she has published over 250 peer-reviewed publications in journals such as JAMA, the New England Journal of Medicine, Implementation Science. She has led, I could go on about all her grants. She's, according to her CV, or the most recent one that I saw, she has 11 NIH grants. For all I know now, she has 13 or 14 or 15, totaling $31 million. She is an associate editor for Implementation Science, which is the flagship journal for our field. And now she has another award to add to her list. I just wanted to say, I know I'm going on, which is probably don't really want to hear her, not me, but I like to, our committee, the selection committee, I like to kind of have their voice here. So one of our committee members wrote, she is remarkably prolific and is able to bridge multiple fields disciplines, not just behavioral health focused, but cross-cutting multiple healthcare conditions issues with approaches from clinical trials, implementation science, policy analysis, behavioral economics, and more. She is incredibly productive and she is highly generative in her research activities. And I do want to note that I've never had this happen before. When I reached out to her to, and we were talking about her coming here and she was preparing, she wanted to know about early career investigators in our department. She wanted to know details about what they do, and so that she can be more helpful as she spends the day with some of them. Just some of our favorite papers, titles: Population Mental Health Sciences, Guiding Principles and Initial Agenda. This one was one I really liked: The Social Determinants of Resilience, a conceptual framework to bridge the policy and psychological research gap. And finally, I just want to say that she was a speaker at the NIMH 75th Anniversary Gala in Washington, D.C., where she spoke on amplifying the voices of all constituents in mental health implementation research. So without further ado, Dr. Beidas.
That was such a lovely introduction. Thank you. Wow. I'm going to put that one. I have this folder in my email that I call my happy emails. I'm going to try to download all the things you just said and put it in there because that was really incredibly special. And thank you all for being here today. I'm really excited to share a little bit of my thinking around where implementation science has been, where it could go, and as it applies to psychiatry. I do want to just start by sharing disclosures of interest related to funding, consulting relationships, and advisory boards. And most importantly, I just want to start by saying that it is a tremendous honor to be here today giving this lecture. Dr. Essock's work in mental health services and policy really serves as the foundation for much of the work that I'll be sharing with you today. And I hope that you'll notice the influence of her pioneering work in scaling up evidence-based practices in mental health care transformation in the work that I present, particularly the focus on partnership with key constituents to conduct ecologically valid and embedded applied work. So keep a look out for that as I go through. So in the time that I have with you today, and I just want to know what time I'm starting, excellent. I have 4 chapters that I hope to cover. I'll start by telling you a little bit about me because I think it's important for you to understand the lens that I'm bringing to this work. And then I'll spend a little bit of time sharing my perspectives on what implementation science is. I know that in looking at the audience that we have experts in implementation science here today, but I find that not everybody in the audiences that I present to has necessarily the same depth in implementation science. I like to do some definitional work. And then for the meat of the presentation, I'm going to share some of the learnings that I've had doing this work over the past 2 decades. So I'm really excited to share that part because I put a lot of thought into kind of where we've been and where we're going. And I'll be really interested to hear what you all think in the Q&A based on your vantage points. And then finally, I'll close with a little bit of future-facing thoughts. But first, a little bit about me. So I do like to start all of my talks with a positionality statement because my identities and lived experiences really do deeply shape the perspective that I bring to this work. So I'm a Middle Eastern immigrant. I moved here from Jordan when I was 2 years old. I'm a mother. I'm trained as a clinical psychologist, and I'm a community member. One of the reasons that I'm so passionate about implementation science is I see it as a tool. I see it as a tool that allows us to advocate and amplify the needs of our communities in pursuit of achieving population health and social justice at scale. And that's why I'm really excited to be here talking with you about that. I do like to also share how I came to be an implementation scientist, because I just shared with you that I trained as a clinical psychologist. And honestly, 20 years ago, when I started that journey, I never would have thought that I'd be doing the work that I'm doing today. So I think it's worth calling out the fact that my path really emerged from a clinical observation that I just couldn't ignore. So for those of you clinicians in the audience, listen to those observations, notice those observations, because they can deeply shape the path of your career. And that observation is well exemplified in somebody who I'll call Emma. Emma was a 16-year-old female who came to the clinic that I was training in, and she had very severe anxiety. And one of the most important things that you should know about Emma's case is that she had seen a number of providers in the community before coming to our clinic, which offered cognitive behavioral therapy for pediatric anxiety. And so she felt quite hopeless when she came to our clinic, and she kind of said, you know, I've tried everything, talk therapy isn't going to work for me. And this is an illustration after she had received an adequate dosage of cognitive behavioral therapy. And what you can see here is that many of the things that she had been unable to do prior to treatment that gave her value and meaning in her life, she was able to return to doing. And after seeing this pattern play out many times, I came to the startling conclusion that kids were not getting cognitive behavioral therapy in the community. And instead of developing treatments, which is what I went to graduate school to learn how to do in an efficacy lab, I decided to go completely in the other direction and to think about how we would get the treatments that we have out to the community. And I got really lucky in that when I first became interested in this topic, the field was kind of gaining steam. And so I kind of had a front row seat at an emerging field. And it really seemed like a potential solution to that observation that I had had about this no-do gap related to pediatric anxiety. So of course, my observation is actually a field-wide issue that we're all well aware of now. And I'd like to offer that, this is probably one of the biggest challenges we face in science right now. So as a society, we spend all this money in discovering various things, but then we spend very little time thinking about how to implement those things so that everybody has access to them. And this is probably my favorite study demonstrating this particular quandary that we're in currently. So this paper came out in 2020, prior to the emergency use authorization for the COVID-19 vaccines. And what's so interesting about this simulation study was it showed that the set of implementation factors would be more important for the eventual effectiveness of the vaccine than the set of biological factors. So we spend all of our time thinking about how we can make things work the best that they can from a biological mechanism perspective, but if we don't implement them, it doesn't matter, right? And so this is a really powerful paper, in my opinion. These papers came out, one in Science, an editorial calling out that COVID-19 has shown the world knowing what to do doesn't ensure doing what we know. For implementation science to make its way into science is a really big deal. It's really exciting to see this. And then subsequently, a couple of years later, it was covered in JAMA by Rita Rubin. So I feel like we've arrived from a scientific perspective. And there's now increasing attention to the fact that this is something that we really must attend to. Now, I'm here in a psychiatry department and institute, so I do want to bring it to our content area of interest. I happen to be focused on child behavioral health, so that's what I'll focus on talking about today. So we know that in child psychiatry, treatment developers have been prolific. We have hundreds of evidence-based practices for young people. But we also know that most kids who need treatment don't get it. Those that get it usually don't get evidence-based practices, and that our effect sizes are attenuated when we take our evidence-based practices into community settings. And I would argue that now, right now, the time has never been more ripe for us to think about how we deploy our highest quality treatments in behavioral health, and to think about innovation as broadly and as expansively as we can, given these headlines. We have 3 organizations declaring a national emergency. We have headlines like these every day in our newspapers. And I'm not telling you anything you don't already know that you aren't living every day, right? So in my opinion, if not now, when? Now is the time for us to really think about how we deploy and scale our best quality treatments in partnership with community constituents. And it turns out that's like the bread and butter of what implementation science is. So let me tell you a little bit more about that going into the second chapter. I do like to share my own kind of personal definition of implementation science before giving you the textbook definition. For me, it's all about making sure that all people are getting the things that work in the community, wherever they're presenting, and moving the needle equitably in health. So that's really what it's all about. I will offer you the National Cancer Institute definition of implementation science, and I just want to call out a couple of aspects of this definition. It's the scientific study of methods. And these methods are all about how we promote the adoption, implementation, integration of various things into routine healthcare and public health settings to improve population health. I'll say that one more time, to improve population health. That is the intended end goal of implementation science. And there's lots of different things that we might be interested in deploying. And you can see, this is a handy mnemonic, the 7 Ps, all the different things that you might be interested in deploying. I want you to just take a second and think about, in the work that you do, what no-do gaps keep you up at night that implementation science could be helpful for? Just take 1 second and think about that. And you'll note as you map these onto these various P words that there's lots of different things that you might be thinking about. And so we do use this language of the thing, and you'll hear me say that throughout the talk. Somebody once stopped me after a talk and was like, I don't think I've ever heard someone say thing so much in a scientific presentation. But it's because if I were to query all of you all online and in the room, there'd be such a wide breadth of various things that we're trying to deploy. I do like to kind of lay out the assumptions and foci of implementation science because they are a little bit different than what you might be traditionally thinking about in the biomedical research paradigm. And the first, and I'm going to keep coming back to this point, and this point is so kind of foundational and seminal to all the work that Dr. Essock did, and is that the work must be done in partnership with our communities. And I'm going to tell you a story in a few minutes about how I learned that really important lesson. But that's really foundational to implementation science. Second, our outcomes are different from traditional studies. So we are really focused on thinking broadly about clinician behavior. And that could be lots of different types of providers. When I say the word clinician behavior within organizational constraints. So often, in effectiveness studies, for example, we're focused on improving patient outcomes within real-world settings. Implementation is a little bit downstream of that and is focused on the clinician behavior in deploying those things within real-world settings and how their organizational constraints affect them in being effective. And I'll say more about that in a bit. The third tenet is that context is not a nuisance. So I have been a part of, and I have collaborated with colleagues who, when they're deploying multi-site trials, they want to make sure the sites that they select are as similar as possible, or that we can kind of control out the noise of the variation that we might have with using different sites, and to isolate the effect of that intervention on the outcome of interest. That's not what we do in implementation science. We recognize that context is queen, that we need to understand it, we need to characterize it using mixed methods and understand its relationship with implementation, and even target our strategies to address that context. Often there is an evidence-based thing that we want to implement within the scope of implementation research. I do want to caution, though, that that's not necessarily required, and that this kind of thinking that I'll be sharing with you today, the more upstream we can go in bringing this thinking to intervention science development as early as possible, the less of a need we'll need for a separate science of implementation. And so I'll say a little bit more about that in the future, but typically, if you were to go to NIMH for an implementation trial, you want to make sure that you have something that you can justify. We have evidence that this needs to be scaled at the population level. And then finally, we have specific frameworks, methods, and strategies. I sometimes see that when new people kind of discover in their particular specialty, and that's not true in mental health, we're actually leaders in implementation science, which is really exciting. People will want to like reinvent the wheel and make up a new science of implementation, but I just want to make sure we're all on the same page, that we have a robust set of frameworks, methods, and strategies to borrow from, so that we're building and producing generalizable knowledge, which is the whole point of what implementation science is. So the last thing I'll say about implementation science is before I share my learnings is share this heuristic tool that I developed with my colleague, Dr. Megan Lane Fall and Dr. Jeff Curran. And it's really a heuristic tool. It's totally imperfect, but it's a way for you to think about where your work falls on the implementation science subway. And I've added a purple triangle at the beginning of this slide to demonstrate that you got to start by identifying that there's some no-do gap. And I'm going to give you 2 examples from my own research over the course of this talk, but I've asked you to also think about no-do gaps that are important to you. And the first question that you might ask is, well, if there's a no-do gap for a particular population or setting, is there a practice of interest that we could deploy here to address that? And, when we're earlier up the kind of subway line, we're typically asking questions about our things, whether or not they're efficacious, meaning, do they work well in tightly controlled trials that really prioritize internal validity over external validity? And that is not kind of what we spend a lot of time focusing on in implementation science. However, there's a real opportunity for us to move upstream and to bring those lenses into the early intervention development efficacy work. And I really hope that, that's a takeaway that you all have from this presentation. But the red line is not typically where we spend our time in implementation science. The second set of questions you might ask yourself if you do have an efficacious treatment is, has that thing shown effectiveness? Meaning, has it been tested in the real world by real world clinicians and shown impact on patient outcomes? If the answer is no, and you're doing that work, that actually the yellow line of effectiveness research by itself, when you're just looking at the treatment in that context and patient outcomes, is not implementation science. And that is like a confusion point for a lot of people. So just want to be really clear about that. However, we have these hybrid trials, which is a type of study that allows you to look at both whether your thing works in that real world setting for patients, and also kind of helps you understand the implementation process and even whether or not you're testing strategies. So there's 3 types of hybrid designs. I'm not going to get into that now. It's too granular, but I'm happy to talk about that in the Q&A. And I want to argue that we shouldn't be doing plain old effectiveness studies anymore. Whenever you're doing an effectiveness study, jump right to the hybrid so that we can be more nimble and rapid in our learnings and get to implementation more quickly. So that is on the green line. And then finally, the bread and butter of what we do in implementation science are mixed method studies that help us understand the context that we're trying to deploy a thing or an intervention within, and then designing and testing our implementation strategies, which are the things we do to help clinicians do the thing in comparative effectiveness designs. And so hopefully this kind of gives you a flavor for where implementation science falls on kind of the translational continuum of intervention and implementation science. All right, now that we've gotten the kind of background out of the way, I'm going to now share with you my learnings over the past 2 decades doing this work. And I want to start with what I think is the most important learning related to relationships. So if you want to have impacts, You really need to invest in authentic, deep, bi-directional partnerships. This work cannot be done by kind of going out to communities and saying, I have this thing that you might be interested in implementing. It really needs to be driven by an ongoing dialogue and discourse around what that community that you're working with needs. And today, I'll be sharing two major partnerships that I've had the great fortune of being a part of. One in the city of Philadelphia, a longstanding partnership around the public behavioral health system. And the second is a partnership that I've had with the Mental Health Research Network, which is an NIMH-funded practice-based research network. We've been working with them since 2015. To think about how to implement secure firearms storage programs in pediatric primary care as a universal suicide prevention strategy. So I'm going to give you examples from both of these partnerships, but I want to start by just highlighting the fact that without these partnerships, nothing that I'm presenting on today would be possible. And we wouldn't, there'd be no results to share. I just want to underscore this point that our communities are filled with wisdom, and our research has to center community needs, acknowledge the systems of power that we're entering within, and be filled with humility. So you might see these thumbs up, thumbs down questions and be like, that's obvious. Like, of course, you're not going to go into a community mental health clinic and say, why aren't you interested in my program? However, I will say, having done this work for some time, is that when I talk to community mental health directors, they have had people ask these questions, and that the questions that we want to be asking really start at the beginning. What keeps you up at night? How can I be helpful to you? What are your strategic priorities? And that means that sometimes you're not going to be the right person to partner with them, and that your job is going to be connecting them to other people who have the expertise that they need. And I do just want to share that I learned this lesson the hard way. I do want to say that I hope that I wasn't asking thumbs down questions, but when I first joined the Center for Mental Health at Penn, which used to be run by Trevor Hadley and is now run by David Mandel, Trevor at the time took me out on this listening tour with all the community mental health clinics that served young people in the city of Philadelphia. And you might remember from my opening that my area of expertise is in pediatric anxiety. And so I kept asking these community mental health directors, do you want to implement the coping cat? Because I know how to do that and I can help you with that. And they all said, actually, that's not what's keeping us up at night. And what we need help with is X, Y, and Z. So I had to completely pivot and change how I did my work and realize that it's not about what I know, it's about what that community that you're working with needs. I like to share my own mistakes so that other people don't make them. I just wanted to share that PCORI has just released a new set of foundational expectations for partnerships and research that I think really nicely kind of buckets or categorizes the values that needs to shape the work that we do in this space. And so I'll just call out a couple, but I'd encourage you to check out their webinar and the documentation that they're offering, because I think it really nicely operationalizes what needs to be done. So for example, how many people here have written a grant and then gone to the community and said, well, I wrote this grant and you gave me a letter and now we need to do this grant. And the community partner says, well, I wasn't really involved in how you decided what outcome you're measuring, or like this thing could never work here, that sort of thing. So really thinking about early and ongoing engagement from the very beginning. And that requires time and trust. So that's just something I'd call out, as well as dedicated funds for engagement and partner compensation. Well, what does that look like for you all when you think about the grants that you apply for example, to NIMH? We try to split the kind of total costs across the organizations that are participating in the work that we're doing so that, our institution isn't getting more funds to implement in a different institution. So just call this out as being a helpful guide. I just want to make the case that it's really important that these values that we bring to the table happen across all the phases of mental health implementation research. And this is a great paper led by my colleague, Dr. Melanie Palacia, and she really tied kind of community academic processes to implementation strategies across the research. And, you know, one thing we hear and we heard so much when we were doing this work in Philadelphia was we're tired of researchers coming and taking what they need and not bringing it back to us, not telling us what they found. And so just really want to highlight the importance of ongoing bi-directional relationships with the partners that you work with across all of your work. So I'll start by talking a little bit about this first set of studies, but I just want to acknowledge that this was work that involved so many people, and I can't get everybody's picture up here. So I've just highlighted folks who are really kind of seminal to that work, but what I'm sharing with you actually represents all of their thinking, not my thinking alone, and I'm very grateful to them for that. So I'm going to kind of get you in the context here. So there's been a 30+ year partnership between the City of Philadelphia Department of Behavioral Health and the University of Pennsylvania Perelman School of Medicine Penn Center for Mental Health. Started by Trevor Hadley, and it's been ongoing, and it's this incredible partnership, just like the partnership that you all share here with New York State. And we have had some I'm not in Philly anymore, but I still think of it as we, having spent 17 years there, incredibly visionary leaders, starting with Dr. Arthur Evans, who noticed that there were all of these evidence-based practices that had been developed in the backyard of Philadelphia and West Philly at the University of Pennsylvania that were not available in the public behavioral health system. And so he launched this effort, and Philly has a very large public behavioral health system, serves over 150,000 people a year, 30,000 of which are children and families. And they have a carve out there where all Medicaid services are delivered through this organization called Community Behavioral Health. So basically, he launched this initiative where he had several initiatives for different evidence-based practices. So there was one for trauma-focused CBT. There was one for the Beck Initiative, which was about general cognitive therapy, to deploy these evidence-based practices in the hundreds of clinics that we had in Philadelphia. And what was really cool about this was after starting that, and I wasn't there for that part of the initial story, Dr. Evans began to notice that there were silos between these different evidence-based practice initiatives. They weren't learning from one another, and they were facing many of the same barriers. And so right around the time that I started at Penn, that this EPIC, Evidence-Based Practice and Innovation Center, was started as a centralized infrastructure within the city, within community behavioral health, to support all the organizations and the clinicians in implementing evidence-based practices. And I actually wrote my K-23 about the creation of this to see what the impact of this centralized infrastructure would be on implementation of evidence-based practices. And what I love about this particular example of a relationship is that it was really iterative. So after Dr. Evans noticed that the initiatives weren't talking to one another, then EPIC was created. And then as EPIC got rolling and we started to understand more about what made it hard to do evidence-based practices, then the system created a designation for clinics and clinicians who were delivering evidence-based practices, along with an enhanced financial incentive or an enhanced rate. So over time, these learnings occurred based on this public academic partnership around how best to do this implementation. And so, you know, at face validity, a relationship in entities doing work seems really valuable and important, I think. But I also just want to share here what kinds of outcomes that robust community academic partnership led to. So I've already described this iterative approach to implementation. We kept kind of learning with all of the mixed methods work that we were doing and changed the approach based on what we were learning in the field. Actual changes in policies and payment structures based on what was learned. And, you know, probably what is most important to me, the ability to shine a spotlight and really amplify the needs of the constituents within our system, particularly frontline clinicians who had not kind of had the opportunity to have their voice heard in that way. And then we were able to show Philadelphia as a national exemplar, as well as create generalizable knowledge and scholarship. Over 50 papers came out of that partnership, and all those papers had community partners as co-authors on that work, because they were integral to the work. So lesson number one, you got to have strong relationships to do this work. Lesson number two is one that I say with humility. Pay close attention and listen, because the initial questions that you come into a context with may not be the most meaningful ones to pursue. And I'm going to tell you why I think that. So I've already described to you that I kind of came into the Philadelphia system while implementation was already happening. And after I kind of did the listening tour and learned that the thing that I thought we should be implementing wasn't necessarily of interest to our partners, I completely pivoted. So for those of you writing your K23 or K01 right now, I think I wrote like 100 drafts of my K before it eventually got submitted. So hang in there. It's important to kind of follow the questions that you're hearing from your partners. But, I went into this K23 planning to understand what happens to implementation of evidence-based practices in a large public behavioral health system when a centralized infrastructure like EPIC is created. And I was particularly interested in understanding the relationship between therapist factors and implementation of evidence-based practice, like their knowledge and their attitudes, and organizational factors, such as the climate, the culture, the leadership, and how that was associated with implementation. So as part of that work, I spent 10 years kind of observing, measuring, partnering with constituents. It really allowed me to take this magnifying glass to the infrastructure of public behavioral health in a leading system. The most meaningful questions I ended up pursuing, this was the paper that I said I would write from the K23 specific aims as the main outcomes paper. But the most meaningful questions that we pursued kind of alongside this main paper came directly from our constituents. And what did we hear? So as part of the work in the paper that you just saw on the previous slide, we surveyed hundreds of clinicians within 30 organizations in the public behavioral health system and asked them about their knowledge, their attitudes, their organizations, and their use of cognitive behavioral therapy, which was kind of the core EBP that they were implementing for young people. And what we noticed is that we had planned to do the kind of qualitative work towards the end of the study. We measured this, did all this quantitative measurement at 3 time points, is that people kept kind of pulling us aside after they completed our surveys. And they said things like, oh, but I want to talk to you about what it's really like to deliver public mental health care. And so we actually started to front load our qualitative work because we realized that we really needed to hear those stories and understand the context. And this was work led by Dr. Becca Stewart, Dr. Danny Adams, and Dr. Brianna Last. And we heard things, first of all, about the immense financial strain that the organizations that we were collaborating with were experiencing. So we heard things like, we're losing our shirt. We hold our breath and pray when we pay people. And this was primarily from the administrators that we did interviews with. But then when we went to explore how the therapists experienced that financial strain, we also realized that the clinicians themselves who were delivering care were experiencing immense financial strain. So we saw that there were relationships with that and turnover. And we also learned that the majority of clinicians within our system owed over $100,000 in educational debt, and 1/3 of our clinicians went without mental health care because of the cost. And these were all things that came out of these kind of informal conversations that we had with people, leading to in-depth, rigorous qualitative work to really understand the context that we were working within. And so, when you look at the results of that main paper that I presented a few slides ago, we saw an incremental increase in use of cognitive behavioral therapy as reported by clinicians over the 5 years after the creation of this centralized infrastructure. And you might kind of jump then to the assumption that the reason it's hard for clinicians to do evidence-based practices is because they don't want to, or because they're resistant. I really don't like that word, so I'm going to put it in quotations. But you can see how what I was just describing, that work really allowed us to amplify the voices of our clinician partners and help shed a light on what it is like to deliver care in the public behavioral health system, which kind of totally changed our thinking and had us kind of reconceptualize around this Maslow's hierarchy of needs for community mental health clinics, where, there's all this stress to keep the lights on, to stay compliant with regulations. And evidence-based practice is kind of like self-actualization. Everybody wants to do it. We think it's important, but it's really, really hard. And so it really changed the way we thought about it. And if we hadn't done that kind of in-depth work that we did because of what our partners told us, not because we came into the work having that lived experience, we would have missed that. And we might have interpreted our findings from the quantitative work very differently. The experiences I just described also shifted us towards how we thought about designing future implementation strategies to better support clinicians. So we asked ourselves, well, what if instead of assuming that we know as researchers or as policymakers what clinicians need, we asked them directly and empowered them as the experts? So this is NIMH-funded work that was led by Dr. Becca Stewart, and we did an innovation tournament, which is a crowdsourcing technique, think American Idol, but for ideas, and asked clinicians, what do you need to be supported in delivering evidence-based practices in your organizations? And what you see here is like one of my still favorite days of my life. We had a gala, we had our commissioner there and our clinicians in the front who brought their winning ideas. And it was just a really powerful day because the clinicians brought their partners, they brought their bosses, and they said, for the first time, we're like up here at Penn in this fancy room getting celebrated for our ideas rather than being told what we need to do high quality care. And just to give you a flavor of the types of ideas that our clinicians shared with us, one idea was related to a better waiting room experience. One of our clinicians described that at the clinic that they worked at, the waiting room was highly chaotic, it wasn't welcoming, and it took a lot of time to kind of get their clients ready to do the work when they came into session. So their idea was making changes to the waiting room to make it more therapeutic, to help clients kind of ready to come into the session and do the work. You won't be surprised based on what I shared about the financial strain of doing public behavioral health work as a clinician and as an organization. Many of the ideas that were submitted related to financial incentives. So paying clinicians for their preparation time, paying extra for evidence-based practice sessions, or a certification bonus. And I'm really proud that our work with the City of Philadelphia allowed the City of Philadelphia to take these ideas and to implement changes in both the financial incentive that they were providing to organizations and also giving recommendations to the organizations to make sure clinicians got some of that incentive. Because in the beginning, only the organizations received the incentive. So the next thing I want to share with you is related to this question of like, well, we only have limited resources. So if you had to put your money down on one set of determinants to focus on to improve quality of care or enhance implementation success, what would it be? For me, it would be organizational determinants or organizational factors. And it's really interesting because in implementation, we spend so much time focused on individual level clinician factors. Like our immediate gut is like, okay, if someone's not doing something, we should train them. And yes, we should train them. And there are other things we have to do to make it possible for them to deliver high quality care within their context. Training is necessary, but not sufficient. And my dissertation was about training. So training is very near and dear to my heart. But over the years, I've learned how important the environment is to supporting clinician behavior change within organizational constraints. And this is the first study that I did. This was a cross-sectional kind of snapshot of the first wave of data collection from my K-23, where I was really interested in this question of, is it the set of individual clinician factors that dictates what they do in therapy, or is it the organizational factors, or is it both? And really what we found was that the set of organizational factors like culture, climate, leadership predicted more of the variance in use of evidence-based practice for clinicians. So this was kind of my first hint in, that I should be attending closely to organizational factors. And of course, there's a whole field of organizational management that to draw upon here that helps us understand why the organization is so important. And we've done a bunch of kind of inquiry in this space, but I'm going to focus on one particular construct for time, and that's proficient organizational culture. And we have a validated way to measure organizational culture, organizational social context measure developed by Charles Glisson and colleagues. And essentially what that construct means is that clinicians in an organization are expected to be responsive to client needs, they're expected to have up-to-date knowledge, and they're expected to be competent. And this is an organizational construct, meaning we measure all of the clinicians' perspectives and then we aggregate it up such that each unit has its own, just one kind of data point. And what you can see here, so on the x-axis we have WAVE. So remember, we collected data 3 times following the creation of this evidence-based practice centralized infrastructure. And then on the y-axis, we have self-reported use of cognitive behavioral therapy techniques. And what's really interesting is that the agencies that had more proficient organizational culture at baseline showed steeper increases in use of evidence-based practice over time compared to those that did not, suggesting that this is a really important construct that we should be paying more close attention to. Now, for those of you in the room who are thinking, well, that's self-report, you know, what people do in a therapy session, I also have harder data here, and we've looked at the relationship between this construct, proficient organizational culture, and turnover, which relates to clinicians leaving their organization, which we know is a huge issue in public behavioral health. And what you can see are the T-scores on the x-axis for proficiency culture at time 2. So it's kind of like IQ testing. The mean is 50, one standard deviation is 10. Anything above 50 is a strong proficiency culture all the way up. And what you can see is that the clinician turnover probability at time 3 reduces the higher the proficiency culture was at time 2, suggesting then that those organizational factors are really important for keeping clinicians within their context. And that's work led by Dr. Nate Williams. So, all right, so we've talked about the importance of partnership. We've talked about listening to your constituents and following the ideas based on what you're hearing. We've talked about how important it is to attend to organizational factors. I could start with this one because it's so important. So I really want to amplify this point that we have to make sure that when we're trying to implement new things within context, that we don't make it harder for clinicians to do their jobs. And after spending 10 years really embedded within these community mental health clinics, I am certain that everybody that was employed within those clinics was trying to do the best that they could. And often they felt a bit like this person where they were trying to keep up with regulatory requirements, trying to see as many clients as they could. And their job was really hard. And then we were adding these complicated evidence-based practices on top of it. And so it just made things harder. So I started to think about bringing in insights from another discipline, behavioral economics, which you may have heard Dr. Dixon refer to in the introduction. So that's something that we've been doing probably in our work over the past 6 years. We've been bringing together behavioral economic thinking into implementation science to think about how we can redesign the environment to support behavior change, to make the right thing the easy thing to do. And, you know, really came to this work from leadership at the University of Pennsylvania, both in the Center for Health Incentives and Behavioral Economics, which Dr. Kevin Volpe leads, and then the Penn Medicine Nudge Unit, which Dr. Mitesh Patel was the founder of. And so we had these strengths in our institution in behavioral economics, and I saw them presenting, and I started to wonder, could we leverage those insights and bring them into our implementation approaches, which often feel kind of unwieldy, cumbersome, expensive, kind of throwing everything at the wall to try to get behavior change. And this is probably one of the studies that influenced me the most. And this is demonstrating a known principle within behavioral economics, which is the power of the default. As humans, we tend not to change our environment's default. So has anyone here noticed that Microsoft Word changed about a month ago from Calibri to Aptos? I can't pronounce either of those things, but raise your hand if you noticed that that happened. Okay, did anyone change it back to Calibri? Okay, we got 2. So you can see very few people, I've thought about it, but I haven't done it. So we tend to go with defaults. So this is that same concept applied in a healthcare setting. So what you can see here on the x-axis is dates in 2014. And on the y-axis, you can see the percentage of medications ordered as generic. And prior to this special date in November 2014, you see a lot of heterogeneity in prescribing behavior. What happened here is that an Epic, or the precursor to Epic, IT engineer changed the default in the electronic health record, where generics became the default when clinicians went in to prescribe a medication. And you see this dramatic change in prescribing behavior. There's a Freakonomics episode called How to Save $32 Million in an Hour on this, if you're interested in hearing more. But the most important thing about this, other than how dramatically behavior changed, is that for Synthroid, which clinicians do not like prescribing as generic, they still kind of went back and changed the default, and they put in Synthroid. So it demonstrates that clinicians still have the agency to make the decisions that they think are clinically most important. And so when I saw this study and I thought about the work that I was trying to do, knowing this won't be a silver bullet, and I just want to be really clear about that, I wondered, could we be bringing some of these insights into that work? And so for the past couple of years, we've really been focused on thinking about integrating these insights into our work. If you look at the ERIC taxonomy, which is our set of 73 and growing implementation strategies that we tend to use in implementation science, it doesn't really include these kind of behavioral economics, behavioral science strategies that we could be leveraging and bringing to bear in our implementations. And so the most powerful one really is this guide choice through default. So if there's something we know absolutely we should be doing, if you can make it into a defaulted behavior, it's much more likely that people will kind of go with it. Dr. Brianna last led a literature review on various ways that nudges or these behavioral economic strategies have been used in healthcare. My personal belief is that we should be incorporating more of this thinking into how we approach implementation science and mental health research. But again, it's not going to completely kind of solve everything, because it's more about being really thoughtful about how we design things versus addressing necessarily structural factors that drive some of the challenges that we have. So just to share a few of those kind of nuggets of principles, the first is the EAST framework. So when you're trying to engage in a behavior change effort, make it easy, attractive, social, meaning use peer comparison, and timely. Often we are increasing sludge or friction when we ask people to do new things. So think about where you can reduce sludge or friction and make it easier for people to do their jobs. Of course, we have to integrate whatever approach we're doing within our workflows. I don't want to see any more implementation studies where we implement something adjacent to a workflow and say, well, in the next study, we'll integrate it into the workflow, because we know that clinicians are too busy to kind of pivot and go somewhere else. We have to do it through the systems that they're already delivering care through. Don't forget to de-implement, so we're not always adding things. We tend to just ask people to do more and more without taking things away. Use data and an experimentation mindset. And then this one is so important. We have to make sure that our efforts to implement things that are really going to require a lot of overcoming of inertia, buy-in, are true organizational priorities. And this is where I go back to the point about embeddedness and understanding what the strategic plan is of the organizations that you're working with, and making sure that whatever you're doing is actually a true priority for them, because otherwise you're just not going to get traction. And when the grant ends, the work is going to go away. So I'm going to share now some of the firearm secure storage work that follows this line of thinking. So we're pivoting from the Philadelphia work to a new example. Bear with me. I do want to also acknowledge all of the people that contributed to this work, because this work represents all of our intellectual contributions. So I'm just going to quickly make the case for why this is a significant problem, and then I'll tell you a little bit about our implementation study. So I know that everyone here in the room knows that suicides are increasing in the United States, and there's been some really influential simulation work that demonstrates that an increase in secure firearm storage could prevent up to 32% of deaths in young people. And I kind of think of this as like a population health universal suicide prevention strategy, given that we know that about half of suicides are by firearms and that firearm attempts are highly lethal. And so when we thought about this no-do gap, we then went into the literature to think about whether or not there was an evidence-based practice for pediatric primary care, which was our starting point because that's a place where we know young people and their parents present. You know, I will say that there's a number of child pediatric organizations that have made recommendations and guidelines that pediatricians should be thinking about secure firearm storage as part of the anticipatory guidance work that they do with parents. So when we went into the literature, we realized that there was an evidence-based practice already tested in a large effectiveness study around secure firearm storage. And the components of that particular intervention were threefold: screening for firearms in the home, having a brief conversation with parents about the importance of secure storage, and giving out free cable locks, which is a really important aspect of the intervention. And I will tell you, I don't have time to get into all the details. We did end up adapting this program and removing the screening and making this program universal for all parents, because 1 in 3 homes in the United States has a firearm. And so there's no reason to ask whether or not someone has a firearm, because that also tends to put people on a defensive stance. So that was part of the work that we had to do to get this ready for implementation. But we also did a bunch of contextual inquiry, or those mixed method studies, to understand, first of all, the current usage of those 3 intervention components in pediatric primary care, the acceptability of those components, and then implementation factors that might hinder or help implementation of a brief secure firearm storage program in pediatric primary care. And this was work led by Dr. Courtney Wolk and Dr. Sherry Yeager-Hyman. So we use the Consolidated Framework for Implementation Research, or the CFIR, for those of you all who are familiar, to elucidate through qualitative interviews some of the factors that might be associated with implementation success or failure. So this is that first line in the green line on the implementation science subway. And we heard the importance of making sure the program was really brief, less than a minute, so it could be delivered in pediatric primary care. We heard about the outer setting or firearm culture and how that might impact in the communities that we were implementing in, the importance of workflow integration, leadership buy-in, and clinician self-efficacy in having these conversations with parents. We then did this process called implementation mapping. It looked like that. That picture helps you think about how we matched all those barriers that we heard in the qualitative work to implementation strategies that we could bring to bear to implement this program. And we ended up with this trial. I just presented like 5 years of work in 2 minutes. So I'm oversimplifying, but it kind of helps you understand how we got here. And I'm happy to talk more about that initial work, because I think it's part of the reason why we had so much success in this trial. So this trial, which we've done in partnership with Kaiser Permanente, Colorado, with Dr. Jen Boggs, and Henry Ford Health with Dr. Brian Amadani, 5 minutes, I'm almost to chapter 4, was testing whether or not an electronic health record-based nudge, so based on those behavioral economic insights I was just sharing, was powerful enough to change clinician behavior around delivering this program, or if a more intensive process that's really at the organizational level called facilitation, which is all about supporting the clinic and implementing a new innovation, was needed in this particular use case. So hopefully you'll kind of hear that the study design explicitly incorporates ideas about both the importance of the organizational unit and making it easier for clinicians to deliver the practice. So our hypothesis is that you needed both. You need to make it easy for the clinicians, and the organization needs to support it. We randomized 30 clinics with over 200 clinicians and over 45,000 well child visits. Half the clinics just got the change in the electronic health record. And basically what we did was we used their well visit document template in the EHR, and we added a prompt about having a conversation about firearms secure storage and offering a cable lock. The other half of the clinics got that change in the electronic health record, plus a year of facilitation offered by employees in the health system to help each clinic figure out how to implement that program in their setting. So like, where do we store the cable locks? Do we leave them out or do we put them behind a drawer? You know, problem solving how one does that particular program. Okay, so I've 4 minutes to tell you what brings me hope about the future. So I'll go through this quickly, but then we'll have a chance in Q&A to discuss it further. I do want to acknowledge that my thinking about this comes from these 3 papers, which were all collaborative efforts. The first, which was really a collaboration with implementation scientists, leaders across the country, thinking about what we're getting right as a field and where we might be going wrong. The Lancet Psychiatry Commission was led by Dr. Beth McGinty and is really calling for transforming how we do mental health implementation research. And then this piece, which was in collaboration with your own, Dr. Rachel Shelton, is really about thinking differently about intervention science going forward. So the first point is that I hope that we can design for dissemination and implementation as early as possible so that we can avoid all of the work that has to go in to picking something up that's already been designed and trying to implement it. You heard me describe how I needed to adapt the program that had been tested in the effectiveness trial. I think the more we involve end users in the development of our interventions upfront, the better. I hope that in the next decade, we have a paradigm shift. Right now, I feel like there's intervention scientists and there are implementation scientists. I actually came from the intervention science world. I hope that in the future, they're going to be melded together. In fact, I'm starting to do work that's more back in the intervention science space and structural level interventions. And so I really think that this linear pathway that we have here, that the subway that I presented is based upon, should look something more like this, where it's much more dynamic and recursive and, our intervention and implementation science is a marriage rather than separate lines of research. Has anyone here ever seen The Impossible Teapot? This is a beautiful piece of art, but imagine trying to pour tea out of it, right? Sometimes I feel like our interventions are a little bit like The Impossible Teapot. So really thinking about co-design of our interventions to center the voice of people receiving or delivering the programs and targeting the context that they play, work, and live in, or human-centered design. And that results in interventions that are more effective, acceptable, feasible, usable, and actually can be deployed in the context in which we hope that they'll be used in. And Dr. Andrea Graham and Dr. Erin Lyon are real leaders in this space. If you're interested, you can see more about their work. We just take too long. We have to ensure that our approaches are more fast and nimble. This paper was one where we made the argument that whenever safe and possible, we should be moving right to effectiveness trials as the most valid test of an intervention is the test of that intervention in the context in which it is intended, particularly those that are building on decades of theoretically informed psychological and behavioral science. So, if we know that the ingredients that we're testing work, we know their mechanisms and we're making small package changes, we can just move right more quickly into doing effectiveness into the context in which they are meant to be tested in. And that really comes from a desire to prioritize external validity. I have been in one too many meetings where, my partners say, well, it seems like internal validity was more important to the people who developed this thing than actually whether or not this thing could be used in my context. And I recognize this is a controversial statement, so I'm happy to talk more about it. But it's our belief. I've already kind of pre-staged this, but whenever you can, if you're doing a pragmatic effectiveness study, do a hybrid study and track what you're doing to implement to move us along more quickly. This is a great paper by Dr. Jeff Curran and team about kind of reflections on doing these hybrid designs. And this paper led by Dr. Brittany Rudd really calls for tracking implementation strategies earlier in effectiveness work. And so she did something really cool where she coded all the suicide studies that she could find, suicide prevention studies she could find that were effectiveness studies to see what implementation strategies were described in the paper. And then she reached out to the authors and she asked them what implementation strategies they used. And it turns out they used way more strategies than they described in the paper. And if we had tracked that and we knew that, we might be able to move more quickly. We must center equity prospectively in implementation science. I'm almost done, I promise. And so, there is no implementation without centering equitable implementation. And these are really great papers if you're interested in reading about this more. But, we in implementation science implicitly thought about health equity. But in the racial reckoning in our country and the murder of George Floyd, there have been a number of thought pieces about how we need to be doing this explicitly, and work led by Dr. Katie Hoskins has helped us think about how to operationalize those recommendations. And so I encourage you to check out this paper, and you all will get these slides since I'm zooming through. All right, my last couple of slides. The next generation of researchers show us that the future is bright. I'm all about the early stage investigators. These are my kids. They are now not this cute, and they're much older, and they would die if they knew this picture was up here. But that's where it's at. That's the future. We need to innovate with regard to our models, training, and funding opportunities, particularly for our early stage investigators, so they can do the work in the way that I just described. And I just want to close out, this is my last slide, by sharing some of the work that inspiring investigators are doing, leading creative and transdisciplinary work to meet the needs of our communities. So Dr. Gina South is at the University of Pennsylvania. She's doing incredible work in greening and place-based interventions to improve mental health, so structural interventions. Dr. Rihanna Anderson is here at Columbia, developing programs focused on racism and discrimination to support the mental health of Black youth. Dr. Morgan Shields has been very focused on thinking about how to implement patient-centered care for inpatient psychiatric treatment. I know that some of you all have worked with her here. Dr. Brianna Lass, their work is really focused on policy-level interventions and their effect on psychological health. Dr. Jessica Schleider, who's at Northwestern, is thinking about how to meet the needs of young people where they seek treatment, which ends up being through social media platforms and with short dosages, single session interventions. Dr. Stephanie Rollin, who's here adapting and testing interventions to reduce violence in young adults with early psychosis. And Dr. Natalie Baris, doing work in machine learning for precision treatments in schizophrenia. I could have spent my whole talk talking about the amazing work that other people, early stage investigators, are doing that is the future of this work, but I hope you see the themes here of the partnership, the structural level interventions, the melding of intervention and implementation science. So in closing, thank you to my team who makes this work possible, and my family. And if you would like to reach out to me, all the ways to reach me are listed here.